Okay, welcome to the Stanford Clinical Lecture Series in Radiation Oncology. Доброго вечора українцям, слава Україні. Here's the slide for Stanford physicians. Stanford physicians can apply for CME credits. I will also post this text number in the chat. And our today's lecture is on radiotherapy for lymphoma, and our speakers are Dr. Michael Bінklі and Maria Vega. Dr. Bінklі is the assistant professor at Stanford Radiation Oncology. His clinical expertise is total lymphoid and total body radiation. He did his postdoc here at Stanford, and he studied the use of genomic signatures to predict response to radiotherapy. And he currently has a lab and a team of researchers trying to identify prognostic and predictive clinical, radiographic, and genomic factors to inform individualized treatment strategies. Dr. Bінklі received the Malcolm Bagshaw Award for leadership and outstanding scientific achievement. Congrats, Michael. And our second speaker is Maria Vega. She's an amazing dosimetrist at Palo Alto. Everybody loves her here. She's the heart of the dosimetry team, and she will be teaching us a total lymphoid irradiation planning at the end of the session. But first, we'll start with the clinical lecture by Dr. Bінklі. Take it away, Michael. I'll stop sharing.
Oh, thanks for the warm introduction and welcome, everyone. I would certainly like this to be interactive, and so if anyone has any questions, feel free to jump in and interrupt. That would be welcomed. As far as the topic, lymphomas are a very, very heterogeneous group of diseases, and it's challenging to think about, one area to focus on. And it's also challenging to think about, one radiation technique. So I thought the lymphoma worth focusing on as far as introduction would be the most common non-Hodgkin lymphoma, which is diffuse large B-cell lymphoma. It's also one of the more deadly types. And so there's still a lot of room left to try to improve outcomes for patients. And so I'll focus on that. And then, as far as radiation techniques, I'll mention a little bit. And then, of course, Maria will give us the full details about total lymphoid irradiation. This opening slide just illustrates that even under the microscope, there is a lot of heterogeneity for diffuse large B-cell lymphoma. So this top left is a classic germinal center DLBCL subtype. So I'll refer to it as DLBCL throughout the talk. The top center one is plasmacytic differentiation. The top right is a CNS in the brain. The bottom left is resembling, say, more of a intestinal, like almost intestinal stromal type tumor. And the bottom right is EBV associated. So any part of the body could be an area where a patient could develop DLBCL. And even within that, as you can see by this slide, it can appear quite differently. And it is highly important to have the tissue biopsy and pathology reviewed by centers that are accustomed to seeing lymphomas, because it can, almost impersonate many other types of cancers. So it's very important to have the tissue reviewed at a center that commonly sees lymphoma. As far as the incidence, this is incidence of non-Hodgkin lymphoma in general. It is a disease of older adults, as shown by the histogram on the left. It's more common in males than females. It's not really well understood why that is. And in this pie chart on the right shows the incidence, relative incidence of the different subtypes. And so almost half of cases are diffuse large B-cell lymphoma, as shown in orange. The lower grade ones are less common, but still also very common. And then you'll see that the T cell variety shown by this cyan color is quite rare in comparison. The staging for lymphomas generally follows the convention of a single lymph node or a single site is stage 1, multiple lymph nodes or multiple stations above the diaphragm or below the diaphragm is consistent with stage 2. If a patient has lymph node involvement above and below the diaphragm, but does not have extranodal non-lymph node involvement, that's consistent with stage 3. And if they have disease above and below the diaphragm, but also involving extranodal non-lymph node, non-lymphoid organs, that's stage 4. There is a few modifiers to the staging, such as the E, which actually represents extralymphatic involvement. It does not mean extranodal, although it's commonly used that way, and there is a lot of similarity. The main difference is that when looking at these different nodal stations on the Ann Arbor chart, Waldeyer's ring and the spleen, they are lymphoid tissue. They are not nodal, but they are lymphoid tissue. So they are extranodal, but they are not extralymphatic. And so it's just a minor difference in differentiating extranodal sites from extralymphatic, which would be, say, lung or intestinal involvement, soft tissue. Those are extralymphatic sites and would be indicated with this E modifier of the clinical stage. And so then today, we'll also go over some of the pathobiology of diffuse large B-cell lymphoma, some prognostic factors that are still used routinely today, and then we'll talk about radiotherapy and indications for radiotherapy. As far as the pathobiology or the origin of diffuse large B-cell lymphoma, this is a B-cell derived malignancy, and I'll show in a minute the lymphomagenesis event can happen during different times in the maturation of the B cell. And as it turns out, depending on when that mutagenic event happens, the genes expressed by that lymphoma are characteristic of what stage in development that B cell progenitor it had progressed through. And so actually the first classification as far as this cell of origin was described here at Stanford. And it was described by a medical oncologist named Dr. Ash Alizadeh. And he published this paper in Nature now 23 years ago, where they used RNA microarrays to characterize the genes expressed for a set of patient tissue cases of DLBCL. And that's shown here on the left in this heat map, and high expression is corresponding with red color. And they clustered the patient samples, and what you can see is there were 2 clusters, and as it turned out, they had high expression of a characteristic set of genes that matched either germinal center B cells or activated blood pool B cells. And so that is how the naming convention for the cell of origin was born. And so since that time, we have identified cases as either germinal center B subtype or activated B cell subtype, so GCB or ABC. We don't routinely use RNA microarrays on patient samples in the clinic because there was an algorithm developed that uses fewer protein markers and is still 80% accurate, known as the Hans algorithm. And that looks at protein expression for a much smaller set of proteins to infer the cell of origin types that Dr. Alizadeh described. And so you can follow this branching diagram. So CD10 positivity identifies germinal center B cell cases. If that's negative, then you look at BCL6 and then further MUM1 to differentiate what the cell of origin is. And that's actually important and becoming more important actually with a few recent trials that have been published. It does appear that the ABC subtype has a worse prognosis, and some medical oncologists even consider giving different chemotherapies for that subtype. And then just going into the pathobiology a little bit, in these germinal centers where B cells mature and where lymphoma genesis events occur, there are dark zones and light zones that distinguish the phase of maturation that the B cell is undergoing. These are where these mutagenic events occur. This is where in healthy individuals, your B cells undergo a lot of genetic changes, and these changes can have errors that occur, and those errors can result in development of a lymphoma because this aberrant cell may gain a survival advantage. And so if the lymphomagenic events occur in the dark zone, that's more consistent with a germinal center B subtype, or if it happens in the light zone, more consistent with the ABC subtype. And notably, the classification of DLBCL was updated just this past year in 2022 with the 5th edition of the WHO criteria. And the main distinguishing genetic structural change that's important to note is if there's a translocation in MYC and BCL2, you can have what's known as a double hit large B-cell lymphoma. And that is different phenotypically and clinically. It behaves more aggressively as compared to DLBCL NOS. So often patients with this double hit receive different and more intensive chemotherapy that we'll talk about later on. And further, with next generation sequencing, there has been a couple of analyses published where with characterization of the tumor mutations present for DLBCL, there have been genetic subtypes described. And so this was one of the first early ones by Schmitz et al., where they looked at a large number of DLBCL cases, just over 100, and they performed genotyping, characterizing the tumor mutations, and they clustered them. And they clustered them into 4 different subtypes that are shown here in the Kaplan-Meier survival curves. And as it turned out, the subtypes were prognostic. And so perhaps this could be an early step towards personalization of therapy for DLBCL, as it has been done for, say, other diseases like lung cancer. So we're not there yet. And the other common critique of this study is that shown in this pie chart in the bottom left, more than half of the cases are not genetically classifiable. And the other critique is if you look at the 2 subtypes that do the worst in terms of progression-free survival and overall survival shown on the right, these are mostly ABC subtype. And so some might argue that, well, ABC subtype we already knew had poor prognosis. While this is academically interesting, it may not be enough to change management of patients based on tumor mutations. So at least not yet. But there has been some investigations in other cohorts of patients with DLBCL that had genotyping done. And these genetic subtypes may in fact be predictive for outcome for patients that get escalation of their chemotherapy. So this was looking at patients that received R-CHOP with or without ibrutinib. And the subtype N1 shown on the far right here, for those that got ibrutinib versus placebo, they are shown in the green curves here. There does appear to be a benefit with the addition of ibrutinib for these patients of this N1 genetic subtype. And so, perhaps in the future, these patients may receive different chemotherapy, and that may eventually help inform radiotherapy indications also. And then this is mainly here for reference, but other groups have looked at this too and developed other genetic classification systems. And so this kind of highlights, again, it's a heterogeneous disease, and there's many ways to cluster these patients. But what is interesting about this study that was published as a follow-up that clusters patients based on tumor mutations is that even for the GCB subtype, that in the prior Shibui cohort, those subtypes seem to have favorable outcomes. This cohort by Shibui seemed to identify this cluster 3 for the GCB subtype that has a poor prognosis as well. So certainly further classification of the GCB subtype could also be helpful. So that was a lot of background on future, hopefully, personalization for DLBCL. I'll kind of shift gears now to what the current practice is and has been, and what are some standard prognostic markers. So this is the International Prognostic Index, and it has been used for decades, and it's been validated in the rituximab era as well. And this is a 5-point scale where a patient is given a point for any of these 5 risk factors: age greater than 60, advanced stage, elevated LDH, poor performance status, or more than one site of extranodal involvement. High risk scores being 3 or greater. And then, this of course has to be modified for patients less than age 60, and that's the modification. So there is a mnemonic to memorize this IPI. It's LEAPS. So L, LDH elevation, E, extranodal more than 1, A, age greater than 60, P for performance status greater than or equal to 2, and S for stage 3, 4. So that's a helpful way to remember high-risk factors. Now, as it turns out, for patients that don't have involvement in the brain or the CSF space, the CNS, there are many who are at risk for developing recurrence in those areas. That is a high-risk event that is associated with a poor prognosis. And so it is important to be able to identify patients that could be at risk for developing the relapse in the CSF space or the central nervous system. It's actually very similar to the overall IPI, 1 point for age, LDH, performance status greater than or equal to 2, stage 3, 4, greater than 1 extranodal site, but they add an additional factor, which is if the patient's lymphoma was involving their kidney or adrenal gland, their risk of developing a CNS relapse is greater than 10%. So that's high risk. These are indications that the patient should receive prophylactic treatment of the CNS with systemic therapy or intrathecal therapy. And then finally, there's another modification for patients that only have involvement above or below the diaphragm, and it just gets simplified a little bit. It's called the stage modified IPI, and it just age more than 60. Stage 2, because the patients either have stage 1 or stage 2, elevated age, LDH, and again, poor performance status. So a little checking for understanding question. A patient has stage 2 DLBCL involving Waldeyer's ring and bilateral cervical nodes. How would you write this stage on your clinic note? So there's a poll. looks like we have stage 2, right? I gave you the stage 2 part, and almost half got it correct, which is stage 2E. E, remember, oh, sorry, excuse me. E is not correct in this circumstance because it's Waldeyr's ring. Waldeyr's ring is extranodal. It is not extralymphatic. And so the correct answer is just stage 2. Okay. So a little tricky. There are a set of guidelines published in North America, the NCCN guidelines, and they give a nice set of recommended workup, such as, physical exam of the lymph node spaces, Waldeyr's ring, liver, spleen, evaluating a patient's performance status, assessing the presence of any B symptoms. There's 3 B symptoms: fever, more than 38 degrees Celsius, weight loss, more than 10% of the body weight within 6 months, and night sweats. And when we say night sweats, we mean drenching, where it soaks through the bed sheets. This B symptom is not formally part of the staging for non-Hodgkin lymphoma. It is for Hodgkin lymphoma, but many studies have shown that it still is a poor prognostic factor when present. So it's still important to assess for these and note it. And then you want to get lab work, including LDH. That's part of the IPI, metabolic panel. PET-CT staging is essential for nearly all lymphomas, including DLBCL. Generally, testing for hepatitis B is done because those patients are going to get rituximab, and that could cause a reactivation of their hepatitis. They often get a echo of their heart because they're going to get potentially cardiotoxic systemic therapy, possibly cardiotoxic radiotherapy, certainly pregnancy test in women of childbearing age. And then these other tests are useful in certain circumstances. Certainly I would say MRI, if there's skull-based involvement, high recommendation for that, because PET scans are not very good at looking at the base of skull or the CNS space. And then certainly HIV testing if clinically indicated. Bone marrow biopsy typically is only indicated if there is cytopenias or if there's some abnormal findings on the PET-CT. Otherwise, if the PET is negative for concerning areas and there's no abnormalities in the complete blood count, no need for a bone marrow biopsy. These are some additional testing. We already talked about this, these protein markers to characterize the cell of origin. But there's some other ones, looking for viral markers like EBV. EBV certainly is a likely trigger for DLBCL in a percentage of cases, so that would be important too. And then there's a nice set of management guidelines. Now, these are just guidelines. It's more, it's important to know the evidence and some of the studies we'll talk about, but they're a nice set of guidelines. And they break it up by stage, so stage 1, 2, or advanced stage, so stage 3, 4 primarily, or some feel stage 2 with extensive mesenteric involvement. Focusing first on stage 1, 2, meaning one side of the diaphragm, there is this cutoff based on size, and it's been shown in many studies that larger tumors involved by DLBCL is a poor prognostic factor for DLBCL. Now, you'll see it says 7.5 centimeters as the cutoff here for what's called bulky. That is controversial. 7.5 centimeters was used in many studies, but not all studies, and it is not the only cutoff that's been used to define bulk. Some studies have used 7, some have used 10, and probably some others have used even smaller cutoffs like 5. And so although this is a guideline, especially in certain anatomic parts of the body, such as head and neck area, where tumors may not even be able to get that large due to anatomic compartments, you can use your clinical judgment to define what is relative bulk. The main differentiation as far as what bulky signifies is likely more chemotherapy, at least planned chemotherapy. And then often radiation is planned for these bulky tumors. And so this is indication number one for consideration of radiation for patients with DLBCL after chemotherapy. Now, for patients that do not have bulky DLBCL, they typically get 2 to 3 cycles. This says, this recommends 3 and then you get a PET CT, but many oncologists may get a PET CT after 2. And then depending on response, and response is defined by the PET activity, and its activity is defined on a 5-point score, where basically 1 through 3, less than or equal to the activity in the liver, that would be defined as a complete response. If it's more than the activity of the liver, well, that's an incomplete response or a partial. If it's significantly higher or has new sites of involvement, that is progressive disease, a score of 5. And so you can see that there's a nice set of recommendations for how to proceed. If they have a complete response and it's not bulky, you can just do 1 additional cycle of R-CHOP and then the patient may be done. If they only got 3 cycles of chemotherapy and the medical oncologist wants to not administer an additional cycle, you can do radiation. There is randomized evidence we'll talk about in a minute where 3 cycles of chemotherapy followed by radiation is sufficient treatment. Those with an incomplete response typically are considered for additional chemotherapy and or radiation. Those with a progression of their lymphoma after chemotherapy may be considered for repeat biopsy and salvage treatments that we'll talk about in a bit as well. So for those with bulky DLBCL involvement, meaning in this case, I would say at least 7 centimeters. This says 7.5. We'll talk about a study that used 7. This is where you can consider radiation, an indication for radiation, even if they do complete chemotherapy with a complete response. So far we've talked about 2 indications for radiation, a short number of cycles of chemotherapy, 3, or bulky involvement, or incomplete PET response, score of 4. So those are the 3 most common indications for radiation after finishing chemotherapy. Now, looking at some of the evidence for this, so these are historic studies that were conducted by the SWOG group, but they enrolled over 400 patients in the 8736 trial to 3 cycles of CHOP plus radiation versus CHOP alone. And on early endpoint, the CHOP plus radiation combined modality had an improved outcome at 5 years. Well, with longer follow-up by 10 years, that difference appeared to diminish. And so, overall, this overall survival benefit that was seen at 5 years of almost 10% was reduced. And so this was a signifier that with full courses of chemotherapy, meaning, in this case, 8 cycles, which is a lot of chemotherapy, radiation may not be required. Now, I will say the curves still do numerically look a little improved for overall survival in the radiation-containing arm. And the other thing is that as time goes on, patients will naturally die from lymphoma or other causes. And so the fact that these curves start to overlap is not too surprising. And there still is this benefit in early preventing early relapses with combined modality therapy. This was in the pre-rituximab era, rituximab being the anti-CD20 monoclonal antibody, and the SWOG group conducted a phase 2 non-randomized trial shown on the far right, where at 5 years with the addition of rituximab, the overall survival appeared to be slightly better, even in a group of patients that had higher risk factors as compared to the results seen in the 8736 trial on the left. And then just a final note, historically, radiation alone had been evaluated for use in treatment of diffuse large B-cell lymphoma. But as shown in these two studies published in the 80s, it's largely a palliative treatment. Combined modality therapy is the definitive, or chemotherapy alone, definitive treatment for DLBCL. So radiation alone is not a standard option that's utilized if the patient's goal is trying to achieve cure. And you can see by even 2 years, the relapse-free survival in the radiation alone arms is in the 40% range, which is not optimal. So combined modality therapy, far superior. So that was shown early on. Now, moving on to recent trials that investigated further omitting radiation for patients with early stage DLBCL without risk factors, there has been 2 randomized studies published. The first one was the French group, the LISA group. They enrolled over 300 patients and they assigned them to R-CHOP. They received 4 cycles of R-CHOP and then received a PET-CT scan. And if the PET-CT scan had a complete metabolic response, randomized to either consolidation radiation or no further treatment. And as it turned out, on their primary endpoint at 5 years, there was no significant difference in event-free survival or overall survival for the combined modality therapy with radiation versus chemotherapy alone. So this was randomized evidence that in patients with non-bulky early stage DLBCL without significant risk factors, so stage modified IPI 0 to 1, and this study defined bulk as less than 7 centimeters, that chemotherapy alone may be sufficient. I will note the incidence of relapse was still higher in the chemotherapy alone group. But again, that was not their primary endpoint. Now, what about the patients that did not have a complete response to 4 cycles of chemotherapy? Well, most of them got 2 more cycles of R-CHOP and radiation. And what's important to note is by 5 years, the group that had a complete response as opposed to the partial responders shown by this dotted line, the event-free survival was actually very similar. And so this kind of suggests that if a patient doesn't fully respond to R-CHOP after 4 cycles, you don't necessarily have to abandon ship and switch to a salvage regimen or CAR T-cell therapy. You can, in fact, continue with a couple more cycles of R-CHOP and consolidation radiation, and patients should do well. And this was the second study published in the PET era that it wasn't looking at a radiation question, but specifically in the randomization, but it was looking at the number of cycles of R-CHOP for early stage, non-bulky, bulky in this case, was greater than 7.5 centimeters, so that would be excluded. And then patients either received 6 cycles of R-CHOP or 4 cycles of R-CHOP, followed by 2 extra doses of rituximab. Radiation was not included as part of this trial. And so what this did show, though, is outcomes are quite good for, again, patients with favorable early stage DLBCL with chemotherapy alone, and there was no difference in 4 or 6 cycles of R-CHOP. And so standard therapy for non-bulky and nodal, non-extra lymphatic DLBCL, standard therapy would be R-CHOP for, say, 4 cycles alone, and you can consider adding 2 doses of rituximab after. And then the third study that was published for early stage in the PET era was this additional study by the SWA group again. They enrolled almost 160 patients in a phase 2 non-randomized trial where they received 3 cycles of R-CHOP, then they had a PET. If the PET was negative, they only got 1 additional cycle the PET was positive, they got radiation and a radio-labeled antibody that's not widely used, known as brand name Zevalin. Again, what they saw was patients did really well with omission of radiation, again, non-randomized. But again, we see for the PET positive group that results were still quite good, just with some additional radiation following their chemotherapy. And so again, when a patient has incomplete metabolic response, they don't necessarily have to move to an intensive salvage treatment. Radiation alone may be sufficient. So incomplete PET response, indication for radiation. All right. So next poll question. Patient has stage 2, again, stage 2 DLBCL involving Waldeyer's ring, bilateral cervical nodes. And they finished 4 cycles of R-CHOP, and a PET CT shows complete metabolic response. Largest size was 3 centimeters. What treatment do you recommend? All right, so we got a sprinkling of answers. So consolidation radiation, I would say, there's not enough indication here. It is not bulky, it is not extra lymphatic, and it had a complete response by PET, and the patient got 4 cycles. So there's not an indication for radiation. So this is actually not a correct answer, at least not without other risk factors. So correct answer here is surveillance. So again, I showed you 2 trials where with 4 cycles of R-CHOP in non-bulky DLBCL, early stage, without other risk factors, chemotherapy alone is a sufficient therapy. And certainly we wouldn't proceed to a salvage treatment at that point, such as CAR-T. All right, so what are some other reasons to consider shortened amount of chemotherapy and radiation? I would say older patients that are at risk for heart disease. So these were a couple of retrospective studies that showed with increasing cycles of CHOP chemotherapy, or R-CHOP, excuse me, the risk of congestive heart failure goes up significantly. And so if you can reduce the number of cycles with consolidation radiation, that's an advantage in reducing risk of heart failure later on. Same thing for cardiovascular disease like coronary artery disease. Again, we see an incremental increase with increasing cycles of chemotherapy that potentially could be reduced with fewer cycles of chemo and consolidation radiation. And actually, another reason that is less talked about is bone mineral density loss is higher with 6 cycles versus 4 cycles of R-CHOP. So again, older patients at risk for falls or hip fractures, other things. If you can minimize bone mineral density loss, that could be extremely important. And then one last study I'll mention in the early stage setting, early stage DLBCL, is a study that we did at Stanford looking at a 20-year experience. And this included patients with high risk features, so as well as low risk. But we included patients with bulk. So, we used a size cutoff of 7 centimeters. We actually did a regression analysis and found that bulky size might even be less than 7. But what we found is that, this stage modified IPI that we showed you earlier, it certainly is prognostic, but what appeared more prognostic is bulky size, shown here in panel C and D, where these dotted lines by 5 years for patients with stage 1 or stage modified IPI 0 to 1 or 2 to 4, if the patient had bulky involvement, that was a higher risk factor than the stage modified IPI itself. And so again, evidence that bulky size, high risk factor, indication for radiation. All right, moving on to advanced stage disease. This disease is primarily treated by systemic therapy because, again, it's, more extensive, disseminated involvement. Most medical oncologists start with 2 cycles of, rituximab-based chemotherapy. It says R-CHOP here, which is most commonly used. And then they get a PET-CT scan after 2 to 4, and tailoring of therapy after that. Most get 6 cycles, and then possibly consideration of radiation. And we see indications again, bulky size, skeletal involvement. Skeletal, remember, is extra lymphatic involvement. So again, that's indication for radiation. And then, no response or progressive disease, well, that may require some repeat biopsy and potentially salvage treatments. And for patients with advanced stage disease, there's actually been some prospective clinical trials that have shown the benefit of radiation. This was in the pre-PET-CT era, done in Germany, but this enrolled patients, elderly patients older than age 60, who received rituximab-based chemotherapy, and they received radiation for bulky sites or extra lymphatic involvement. Well, as it turned out, they tried enrolling a group that omitted radiation for those indications, and they only enrolled 47 patients because this was closed early, because an early analysis showed outcomes were significantly worse for event-free and a trend for overall survival. And so again, indication, even in advanced stage, bulky, extra lymphatic involvement, consider radiation. And this was another study by the German group again, looking at focal bone involvement, where again, it appears the difference may be even more stark for focal bone involvement. Those that got radiation had significantly improved event-free survival compared to those that got chemotherapy alone. And then in younger patients with higher risk disease, including bulk or age-adjusted IPI of 1, there actually was just publishing of the Enfolder trial in Germany. A large number of patients enrolled, and those that qualified for radiation were randomized between chemotherapy regimens given every 2 or 3 weeks, with or without radiation. And what they found is that the 3-year event-free survival was superior for the radiation-containing arm. So again, even in this younger group, radiation appears to improve event-free survival. No difference in overall survival, likely because there's a lot of effective salvage treatment options. There's an ongoing study that again is looking at omitting radiation for patients with bulky disease, known as the Optimal 60 trial in older patients. And this was an abstract form that suggested with a PET complete response after chemotherapy, that perhaps using that PET to guide whether or not a patient needs radiation, the outcomes may be similar to that Recover 60 arm, but we have not seen the actual paper published, and this was published in, the abstract was presented in 2017. So far, no published paper that suggests, again, for patients with bulky disease that you can safely omit radiation without compromising disease control. Now, regarding chemotherapy, R-CHOP is the standard chemo for DLBCL. It actually was compared to a more intensive regimen known as dose-adjusted EPOCH with rituximab, where doses of chemotherapy are progressively increased until a patient becomes neutropenic or thrombocytopenic. And this regimen is associated with higher hospitalization rates. And although many expected it might have improvement in outcomes at 5 years, no difference. Although I will say this regimen is used for those that have double hit DLBCL. And then most recently, the first regimen to show superiority to R-CHOP was just published recently. And this is the POLARIX trial that enrolled patients of a wide range of almost all ages, high risk factors, IPI 2 to 5, And they randomized them to a monoclonal antibody for CD79A plus RCHP, where they omitted vincristine, which is associated with neuropathy, and they compared it to standard R-CHOP. And what they found was there was a small improvement in progression-free survival with the polatuzumab RCHP compared to R-CHOP. When this was presented, many felt they would still give standard R-CHOP and that it wouldn't be enough to change their practice. But I said this would come up again, and here it is. The ABC subtype appears to have benefit, and this has been shown in other studies as well, with polatuzumab RCHP compared to R-CHOP. And so many medical oncologists, especially for patients with ABC subtype and high-risk IPIs, consider pola RCHP. All right, this is our last poll question. What is not an indication for consolidation radiation? All right, so extra lymphatic involvement, that is an indication for radiation. Bulky size, I think we talked about half a dozen studies that showed it is beneficial. Incomplete response to chemotherapy, we also talked about that. Head and neck involvement, not necessarily an indication for consolidation radiation. It's not extra lymphatic, not necessarily required. The last slide I'll end on is, when a patient has relapse or refractory disease. This is a third of patients. It is a high-risk event. These patients then are considered for CAR T-cell therapy or bone marrow transplant. And this segues nicely into Maria's slides, because bone marrow transplant is often autologous, and total lymphoid irradiation, total lymph node irradiation is often included prior to autologous stem cell transplantation. And so this segues very nicely into her slides. Unfortunately, this is still about a third of patients. And so there is definitely a lot of room to improve outcomes. And bone marrow transplant with TLI is a highly important part of that. The last thing I'll mention is there's new indications for radiation prior to CAR T-cell therapy. This is a protocol we use prior to it. I'll just say we do 5 or 10 treatments to try to cytoreduce this. So just to wrap up, to allow Maria enough time, DLBCL is the most common subtype of non-Hodgkin lymphoma. Indications for radiation haven't changed even with new data, and are largely 3 cycles of chemo for early stage, initial bulk, extra lymphatic involvement, or persistent avidity on PET-CT. Certainly could be palliative too. And with that, I will happy to answer any questions if there's time, but otherwise, Maria, feel free to.
Thank you, Michael. Can you please comment on the prescription doses?
Yeah, that's a good question. And I didn't talk too much about it. So basically, if somebody has a complete response, 30 to 36 gray. If somebody has an incomplete response, 40 to 45 gray. Those are common doses.
Okay, thank you. Maria, go ahead and share your slides.
Thank you very much, Dr. Bінklі, and thank you so much, Natalia, for the opportunity. Total lymphoid irradiation. When do we use TLI? We use TLI prior to bone marrow transplantation as part of the preconditioning regimen. This suppresses the immune system and partially ablates bone marrow to prepare for the allogeneic stem cell transplant. The main OAR we look at is the hard dose, and try to keep that below 8th grade or not much higher than 8th grade if possible. The most common prescribed dose is a 12th grade in 10 fractions, and that is a BID on the last day. Simulation. We position the head first supine. The head goes in a C-TEMO with chin hyperextended, long pad abutting the C-TEMO, a TLI board, arms akimbo, legs on knee fix, and foot fix. All these devices help maintain the treatment position for a long period of time, assist with patient comfort and daily setup reproducibility. These patients can be on the treatment couch up to 40 minutes for the simple fact that we use 3 isocenters. The basis of a robot simulation setup makes the delivery of the plan much more efficient. This slide demonstrates a patient going through our CT scanner. These pictures show how we use the lasers to align the patient. The BBs are these radio opaque markers that are placed on the AP, right lateral, and left lateral. We also use anatomical landmarks to align the patient. The knee fix helps with pressure under the spine. The foot fix helps avoid the hip rotation. The 3 BBs placed are what ends up representing our user origin for treatment planning. We have a CT slice thickness of 5 millimeters. For contouring, we can use AI for normal structures. The organs we contour are the cord, larynx, thyroid, heart, lungs, kidneys, and breast in females. The CTV plus PTV include lymph nodes and the spleen, as Dr. Bінклі was mentioning, how important it is to, it's part of the lymphoid tissue. So those are outlined by the residents and approved by the faculty. The treatment planning placement is APPA, and so for the mantle, we often use 6 MV from the anterior and 15 MV from the posterior. And for the periaortic spleen, we use 15 MV. The pelvis is 15 MV as well, but depending on the nodes, you could end up using mixed beam. Mantle borders. The superior border is the superior border of the thyroid cartilage. The inferior border is above the left hemidiaphragm, keeping in mind the superior border of the periaortic spleen field. The mantle blocking. We have a larynx block on the AP, we have humeral head blocking, and inferior border of the axilla. And for the lung block, it starts at the inferior edge of the clavicle head. It's about 1 cm below. Lateral border is the inside chest wall rib shadow. The mediastinum is about 6 to 8 centimeters in width. And on the hilum area, if necessary, add seroband to shape around the curve of the lung block. The superior border of the periaortic spleen. The superior border of the this is in my way here. Okay, sorry about that. The superior matches the inferior border of the mantle. This is for the periaortic field. And the inferior border is about the L4-5 interspace. Again, keep in mind the superior border of the pelvis field below. Around the spleen is about the 1.5 to 2 cm margin. However, the left kidney is underneath the spleen, and we could be more conservative in that area. As a matter of fact, the MLC is a little tighter in that the region of both kidneys. The DVH for the kidneys depends on the protocol we are using and the total dose, because we also do the kidney transplant treatment planning, And so for those patients that come in with the one kidney, we block it completely. So the next is the pelvis field. The superior border is the match of the periaortic spleen field. Inferior border is about the 1 cm below the ischial tuberosity or lesser trochanter. We block the midline part of it is a block. The superior edge of the block is the widest portion of the bony pelvis. And laterally, it's to the obturator fossa. Okay. Not sure why it's not going. Okay, apologize. I'm not sure why the slide is not proceeding to the next one. Okay, I'm just gonna go this way. Okay, sorry about that. So for the calculation, this is the beam side view of the mantle. We use a calc point, as you can see here, pointing with this arrow. And where I place the calc point, that's where 100% you get 100% of the dose. And this is the sagittal view, and this is the calc point here. And the yellow represents the 100%, and the green represents the 95%. The pink is the 105. So here is this is the posterior spleen field, and as you can see on the superior border here, it's more conservative, and the reason is because the heart is directly superior to the spleen, and we can sometimes be conservative on this area depending on the total dose. And again, here is the sagittal view of the periaortic spleen field. And so again, the yellow is 100%, and here we can see that the hot spots are more anterior and posterior, depending on the separation of the patient. We always end up with hot spots anterior and posterior. So here is the pelvic field with the MLC. We have MLC limitations occasionally with these. We can only, the MLC can only travel inferior so much. So we end up with a triangle where it's not completely blocked here. And so what, if the nodes are drawn more generous, and with the discretion of the MD, we sometimes close the white to a little bit more, and we still get all the 95% coverage here. Here is the coronal view, again with the calc point, and making sure that it's away from the MLC and not in air. So for the global max, this is an example of field and field. When the plan is over 110 hot, we use field and field. And so we move the MLC and block the hot spot. The field and field are not able to merge because it's too large. And so we do end up with a field with sometimes 10 monitor units. However, it does help with to reduce the global max. I don't know why my slides are doing that. Okay. Okay. So this is the planned sum of the entire TLI. This is the composite. The composite is important to check because this is where you can easily see the global max and if there's any overlap. This shows the DVH of the cumulative dose. And this slide here shows the similar triangles to prevent the hotspots. I'm gonna, so one of the things that as a planner, you always keep in mind is the similar triangles. So I'm gonna go back to the beam side view of the mantle and show you what I'm thinking as I'm doing the plan. So going back here, when I'm placing the beam, I look at, and I want to end up with the perfect divergence and similar triangles. So I look at the field size of the mantle, and I see where the central axis is, and I look at my length from the central axis. Well, first, keep in mind that the collimator is turned 90 degrees for all the fields because we use the MLC to maximize the blocking. There's a lot of blocking in the center of these fields. And so to minimize the Saraband, we use the MLC for a lot of this blocking. So keeping that in mind, our X and Y here are in opposite, they're different directions because the collimator is 90 degrees. So the length from the central axis to X1 matches the length of the X2 to the central axis of the periodic field. And the same thing is for the bottom portion. From the central axis of the periodic field to the X1 matches the field size from the pelvis from the X2 to the central axis. So that's what I'm thinking when I'm placing my fields during my planning. So going back to where I was, okay, so the kidney we do a lot of kidney transplants in our department as well. We use the same technique. Again, we use the MLCs to our advantage. These patients do have a different, it's different because they come in for 2 scans. The first time around, they come and get scanned, and we do a preliminary total lymphoid plan, and then they return the day of the transplant, and they get their surgery in the morning. Then they come in and they get scanned again in our department, and we fuse the 2 scans from prior to the day of the scan from the day of the surgery, and we locate where the kidney is. And sometimes the kidney is placed in a really convenient area where we don't really have to modify 2 plans. But in this slice, I can see that the surgeon put this, the kidney, not knowing, of course, right in between the junction of the periaortic and the pelvic field. It's a little inconvenient for us because we have to edit both plans, but that's okay. It's very easily done. So we outline the kidney, and in this case, we had to edit the periodic field as well. So we pull in the MLC and block it completely. And so but in this case, we block the superior border of the pelvic field as well. And this was a patient, a female, that we also needed to block her ovaries with Saraband. I don't know why it doesn't stay. It's going to be there. Okay, so the next slide should be, I just wanted to show that the DVH of that, the kidney transplant patient, and it's
Maria, do you want me to drive the slides? If you can
yeah, that
stop
would be
sharing.
great, Natalia.
Yeah.
That would be great. Thank you. So let's start right where the kidney transplant patient.
Sounds good. If you stop sharing, I can share.
Yep. Done. Thank you. Okay. So going, can you go back to where the kidney transplant? Okay, right there. Thank you. Okay, so this was the last discussion about the kidney being blocking the kidney. So let's go ahead to the next one. Okay, so the DVH for the kidney transplant includes the thyroid, new kidney, and the new ureter, and the ovaries PRV. So these patients, we also block the thyroid APPA. So they're a little bit different workflow, but it's really important to do that. Next. So to make it easy for the RTTs, considerations during planning. Avoid making unnecessary shifts from the user origin. For example, use the same right to left for planning, the same tabletop, only have shifts in the Z direction, supinance. No skin gaps. Instead, we write in journal dosimetric shifts. This is an example, this is just an example of how we write the notes in journal. The TLI plans have a dosimetric shift, same tabletop for the 3 plans. So the mantle, the ISO shift from the CT ref that's where we place those radiopaque markers that I talked about earlier. So we move 20 cm superior, they all have the same tabletop. And then for the spleen, the ISO shift is from the mantle's isocenter. So it's 20 cm inferior. And the pelvis, the isocenter is from the spleen isocenter. So it's 26 cm inferior. The patient is on the couch for a long time because they get the KV imaging for the 3 plans. The KV image is approved by the faculty MD and part of QA's physics second check, QA scripts, and weekly QA chart check. Other lymphoma techniques. So when you so yes, we do VMAT head and neck treatment planning for lymphoma, and as you can see, the VMAT IMRT does a great, beautiful job carving the contralateral area where we don't need to treat, and so it's fantastic. It's something that you can't beat with 3D planning. And this was a case that I just wanted to show. This was a lot. This is a modified mantle plus abdominal PTV. This patient had previous treatment, and but the total dose is low. It's only 200 times 2. And this is what the fields look like. So I had 5 fields, partial arcs, and because we have a limitation on how we 14 cms with the X in the X direction, so they're partial arcs, and so this is what I ended up using for that technique. And as you can see, there's that PTV far away from the mantle PTV, but we captured everything. And so here is the DVH for that. It's all very low dose. Other things to consider. So Saraband. We are moving away from the Saraband. As you saw on the previous slide, we have the CERVIN mixed with MLC. And so we are now 3D printing all the electron blocks. And on the we also have on the lower right-hand corner here this pink one. This is a 3D lung block for photon fields. This is a project that South Bay has been working on, and it's coming soon. Things to consider: tested shields. These are spherical shells of lead. Ideally, we should simulate with the matching rubber surrogate to get positioning right. We have 3 sizes. The RTTs usually find the large, medium, most convenient fit. These are all lead. And this black thing here is this is a 3D printed stand. It's used to make it easy for the positioning of the spheres. Thank you so much, you guys, and sorry about those hiccups. I really appreciate the opportunity. Thank you.
Thank you so much, Maria. I will open the floor for questions. Unfortunately, Dr. Bінklі had to step away to attend to his patient. But if there are any questions to Maria, we'll take some. No questions? Okay. We'll conclude this session. So next session will be on prostate, VMAT, IMRT, and SBRT on Friday. See you next Friday. Thank you.